Okay, so now let's start session one, Health IT's impact on quality of care. The first presentation, the first contribution we are going to see is Health IT and Ambulatory Care Quality, will be presented by Scott Laughery of the University of Virginia. Take it away, Scott.
My name is Scott Laughery, as mentioned. I'm a graduate student in economics at the University of Virginia. This paper is co-authored with my dissertation advisor, Amalia Miller, as well as Catherine Tucker and Carol Rowan-Gressens. So the question we address is, how does health IT affect the quality of care in the ambulatory setting? We're going to measure ambulatory care quality using ambulatory care sensitive hospitalization rates, calculated using data from Medicare inpatient records from 2003 to 2012, and supplemental data analysis based on HCUP data. And we estimate, we get our estimates by differences in differences with county and year fixed effects, as well as county year varying controls. And the result ultimately is we find that there's a significant reduction in ambulatory care sensitive hospitalizations in counties that have greater adoption of ambulatory health IT. Why are we interested in ambulatory health IT? Well, it's been relatively neglected by policymakers. The HITECH Act creates incentives for eligible professionals and for hospitals, but not for ambulatory facilities. And yet, in spite of that, the Affordable Care Act has a significant focus on shifting care from expensive hospitals to ambulatory facilities. And this is motivated by research such as Jiang et al. 2009 that found that in 2006 alone, there are 4 million preventable hospitalizations costing $30 billion. Also, research on the effects of health IT have so far been largely focused on the hospital setting. So we're extending the literature by examining the effects in the ambulatory setting. The potential mechanisms by which health IT might affect the quality of ambulatory care, certainly improved record keeping and information flow that's been shown to have the greatest effect for patients who are switching providers or switching settings of care. Health IT in the ambulatory setting might include decision support functions that increase standardization of care, or consumer applications that involve consumers in participating in managing their own care and following treatment regimens. Our empirical approach is differences in differences. We build a county year panel using a county measure of health IT adoption and calculate ACS hospitalization rates at the county level. Excuse me. We control for time-varying demographic, economic, and healthcare variables. This equation, I denotes county, T denotes year, ZIT is our set of time-varying controls, and beta 1 is the parameter of interest. And in all specifications, we're going to weight by population and cluster at the county level. Our data on ambulatory health IT comes from the HIMSS analytics database, which includes 20,000 ambulatory facilities in recent waves of the database. An important feature of the HIMSS analytics database is it only includes ambulatory facilities that are linked to a hospital system. So this potentially limits the generalizability of our results, but it also potentially focuses our analysis on the subset of ambulatory providers that are the most, potentially have the most to gain from health IT because they have natural partners with which to share information and improve coordination of care. We identify the health IT adoption using the contract date in the 2012 database. Our data on ACS admissions, I said, come primarily from the Medicare inpatient standard analytic file limited data set. This includes 100% of hospitalizations of Medicare beneficiaries between 2003 and 2012. We supplement it with data from the nationwide inpatient sample and the CHIDS inpatient database between 2000 and 2010. And we identify ACS hospitalizations using the Prevention Qualities Indicators module developed by ARC. So here's some summary statistics. I'd focus your attention on the first three. Ambulatory EMR adoption is our main treatment measure. That's an indicator of the fraction of providers in a county that have adopted an ambulatory EMR system, which is our main measure of health IT adoption in the ambulatory setting. And the mean over the sample period is 0.45, but that really increased substantially over the course of the sample period, from 0.22 in 2003 to 0.68 in 2012. The ACS count is the number of hospitalizations in a county that are identified as ACS, and the rate is our main outcome measure, and that's the number of hospitalizations per 100,000 people over the age of 65. And as you can see, our control variables include measures of healthcare provision and economic conditions in a county. So these are our main results. In each, the outcome is the ACS hospitalization rate. In the first column, the point estimate means that for an increase in the ambulatory EMR adoption in a county of 0.45, which is the mean increase we observe over the sample period, the ACS hospitalizations in that county fall by 104 per 100,000, which is about a 1.6% decrease. Column 2 includes county year controls, and that's our preferred specification. And column 3 shows that, that the result is robust to the inclusion of state-specific linear time trends. In each of these, by the way, our sample consists of about 2,500 counties. So we perform a number of robustness checks. For example, we consider whether the decrease in ACS hospitalizations are attributable to decreases in chronic versus acute hospitalizations, chronic being conditions like COPD or hypertension, and acute being bacterial pneumonia, for example. And we find that ambulatory EMR adoption reduces both. We also find significant declines if we use the ACS count as the outcome or the natural log of the ACS rate. Also, if we restrict our sample to counties that have relatively good data coverage in the HIMSS analytics database, we find that we still have this effect of reduced ACS hospitalizations associated with greater ambulatory health IT adoption. We do find differential effects by age. These results that I presented are calculated using Medicare data, and so naturally we'd wonder whether the same results can be found in younger populations or populations perhaps without insurance. So as I've mentioned, we calculate the ACS hospitalization rates again using the nationwide inpatient sample. And again, we find that for patients over the age of 65, there's a statistically significant reduction in ACS hospitalizations. But for younger adult patients in the NIS, the point estimates have the same sign, suggesting a reduction in ACS hospitalization, an improvement in quality of ambulatory care, but the magnitudes are much smaller, and the effects are not statistically significant. Also, we consider pediatric care using the CHIDS inpatient database, and the signs of our estimates are inconsistent and statistically insignificant. So this is really an area for future research, how ambulatory health IT affects outcomes for people younger than 65, because these results that we found might suggest that the effects are really concentrated among the elderly, but it could also just result from data limitations in the HCUP data sets, which are not particularly conducive to this type of county year level analysis. So, in conclusion, our paper makes two main contributions. First, it contributes to the literature on identifying the settings in which health IT improves patient outcomes. Previous research has found improvements in the hospital setting, and we extend that literature by finding improvements in the ambulatory setting as well. Second, we contribute to the literature on identifying which patients benefit most from health IT adoption. So the literature has found that the most vulnerable patients that benefit most from continuity of care experience the greatest benefit from health IT adoption. And we find that the oldest patients benefit most from ambulatory health IT adoption. And we do make a policy contribution. Our findings suggest that we find significant reductions in ambulatory care sensitive hospitalizations resulting from introduction of ambulatory health IT. And so the HITECH Act gives incentives for eligible professionals and for hospitals, but not for ambulatory facilities. And so our research suggests that there's no reason really to exclude ambulatory facilities. And the Electronic Health Fairness Act of 2015, currently before Congress, would exempt ambulatory surgery centers from meaningful use thresholds for eligible professionals. And while there is a good argument for that, I think our results suggest that there would be a cost from dulling the incentive for health IT use in ambulatory surgical centers. Okay, thank you.
Thanks so much for having me. And you pronounced my name right, the first and the last name. I feel a little bit like the Easter Bunny or Santa Claus because I come here every year. So I don't bring any gifts, but except for these slides. But it's awesome that you keep inviting me back. So I don't know how bad it's going to get before you stop inviting me. But let me just, since I don't have that much time, let me just jump right into my comments. So this paper looks at the effect of the adoption of health IT in the ambulatory care setting on ambulatory care sensitive hospitalization rates at the county level over many years. And the identification strategy that the authors use is straightforward difference in differences, estimation. So, one immediate question I had that I didn't see in the paper was how much variation do you have in adoption rates over time? So that would just be informative because that's kind of key to your identification strategy. And you could also compare early versus late adopters, right? So, for instance, if you have bunching at certain dates, that would allow you to establish more credibly that adoption was exogenous, was orthogonal to other determinants of ACS hospitalization rates, and if you compared early versus late adopters, there may be additional policy implications to be drawn from that. You would expect that early adopters might have the strongest incentive and might, as a result, or the early adopting counties might have the strongest incentive, and as a result see the strongest effects. Then again, there's a recurring discussion about the cumulative effects of health ID adoption across the country, and of course technology changes over time, so late adopters may derive a benefit there. One key assumption with difference in differences estimates is always that that the change in adoption status from not having adopted to having adopted is orthogonal to all the other possible confounders that might drive your outcomes. And one important correlate might be the adoption of health IT by hospitals and primary care physician practices in the same counties that you're looking at. So I would be interested to see if your results are robust when you include the concurrent adoption of health IT in the hospitals and practices in the counties that you're studying. And this might actually inform policy as well, because you might wonder, well, did Congress really have to fund ambulatory settings? So if it turns out that adoption of health IT by hospitals and practices was already sufficient to drive down ACS hospitalization rates, then the case for carving out special incentives for the ambulatory setting might be a little weaker than you think. It also might be helpful if you simply try to replicate what your colleagues your co-authors have done. Since you have a county level data set, that's, I think, a really important contribution, and it's novel. Of course, it's a reduced form, and it's not quite clear. It would be nice to see if you were able to replicate the results that Miller and Tucker have found when they used facility-specific data, right? So that would be interesting to see. You mentioned yourself that it would be valuable to study the mechanism. In the data, I believe you have broken out specific health IT functions. So to the extent that there was variation there, it might be interesting to study that, and also to relate those differential adoption patterns of various technologies to the admitting diagnoses. So because you just use a catch-all ACS hospitalization rate, if you can break that out, that would be interesting. And then finally, was it worth it, right? So your bottom line conclusion is that raising ambulatory IT adoption by 45% in a county reduced ACS admission rates by 1.6%. So if you could relate these two figures to dollar figures, then we might get a better sense of what on balance was gained by this. Of course, health IT adoption did not just possibly reduce ACS admission rates, but other outcomes. But it would just this could be a back of the envelope calculation, just to give us a sense of what on balance was gained. Thank you.
Thank you.
We don't want IT to stop to prolong our process. So my name is Ruirui. I am a PhD candidate in economics from the City University of New York. So I am very glad to be here to be able to present my work, which is talking about the heterogeneous effect of EMR system on the hospital efficiency. So I believe many of you have heard about this. That's the IT paradox. It does not only exist in the healthcare system, it exists in many other industries as well, as economists have always been trying to find out the exact IT impact. And empirically, it has been very difficult to do, not only in healthcare market, but also in other industry. Theoretically, there is one explanation of saying why it is very hard to find any impact of the IT system, and that is called the redistribution of profit. And I would like to call it the redistribution of benefit. So when you are thinking about, once there is a new technology that is introduced into the industry, not everyone is affected in the same way. Some maybe benefit more, some may be not seeing so much of benefit, and some may be seeing the effect happening in the way that we're not hoping it's to happening. So there is this redistribution. This redistribution is hinting us one thing, and that is the potential heterogeneous effect of the IT system. So that's from the theoretical part. Empirically speaking, so Brian Hofson, the professor from MIT system, from the MIT Business School, they have used disaggregated level of data, and they were able to find some significant impact of IT system on several other industries, such as manufacturing. And they were saying that once you use the disaggregate level of data, it is much easier for you to identify some variations, which it is very difficult to find in an aggregate level of data. So empirically speaking, it is possible to find IT impact if we are using disaggregate level of data set. So about my data, there are two major parts. One is from the HIM analytics from 2008, and the national inpatient sample from the ARC project HCUP project. And also I'm using the AHA cross-link file to link these two together. Another file that I am using is the Dartmouth Atlas Hospital Referral Region file, and that is going to define the hospital competition market that I will be using in my identification strategy. A little bit more about the data set. I am dropping patients who are transferred from other hospitals, so I'm only looking at the patients who are originally admitted to the hospital. I drop those who are giving births at the hospital, and only keeping the hospitals that are linked between those two major sets, the HIMSS and the NIS set. And my sample finally contains more than 1,200 hospitals over 7 years. A third of the hospitals appeared only once, because NIS is a repeated cross-sectional, it's not a panel data. Another third of the hospital appeared twice during the 7 years, and the rest appears more than three times or more. And the final discharge level observations contains more than 23 million. This is to give you an idea which states are covered in my analysis. So most of the high-density states are included, except maybe for Texas, where they do not allow the identification of their hospital, so that I cannot identify them. I cannot link them to HIMSS. The trend in the EMR adoption, I have two measurements of the EMR. One is the enterprise EMR system. The other one is the EMR system plus the CPOE. The CPOE added on to EMR system is obviously having much lower adoption rates over time, and the rate shown up here is consistent with the results that have been found in previous literature. So basically by the end of 2008, the hospitals that are adopting both EMR system and the CPOE system are about 27 to 28%. So my hypothesis here is, first of all, EMR system will reduce length of stay, because EMR system are supposed to replace the paperwork and makes the communication more efficient. And more importantly, EMR systems are supposed to reduce medical errors, to let the doctors respond to some emergency cases more efficiently. So in general, we would expect the length of stay to be reducing with the help of EMR system. And also at the same time, the U.S. hospitals are not encouraged to prolong their patients' length of stay, because they are not getting paid by how many days the patients are staying at the hospital. So they should not have any incentive to prolong the process. My second hypothesis here is that the heterogeneous effect of the EMR system, it is unreasonable to believe that all the patients who are admitted to the hospitals are affected in the same way. First of all, patients are of different demographic background. Patients are different based on their medical complexities. And also, there may be heterogeneous effect based on hospital levels. Maybe the larger the hospital is, maybe the more productive they are, and maybe they have better labor complementary to their IT system here. So the hospital characteristics may also be the source of the heterogeneous effect. There can also be a heterogeneity based on the distribution of length of stay. In other words, when you're thinking about the patients who are admitted to hospitals with only 1 day, and you compare that with the patients who are admitted to the hospital and staying for over a month, who is the one going to be affected more from the system? So that's the distributional heterogeneous effect. In previous literatures, we have seen researchers trying to find out the heterogeneity among inpatient sample, and I am citing Jeff's paper here. It is a brilliant paper. The only thing is that they have to make an ex ante assumption of how we are separating the different groups of patients. They have to make decisions saying that, okay, here is the sicker group, here is the relatively healthier group. And this paper of mine is taken from another angle, from the applied econometrics level, and I am saying I don't have to make the priori assumption here. I am only saying that I know heterogeneity exists, I am not putting any more assumptions on that, and I will let my model tell me where the source of heterogeneity comes from, because all the reasons for the heterogeneous effect, they are not mutually exclusive to each other. It can be working together. Patients' ages, patients' medical complexities, they can be working all together to determine the heterogeneity. The identification strategy in my paper is mainly using the instrumental variable. I am using the focal hospital's competitors' adoption rate 1 year ago as the instrument for the hospital's own decision of whether to adopt the system or not. And the hospital competitors are defined by the hospitals within the same HRR, the hospital referral region area. And just a little bit more of the instrumental variable here. I am using the two sample IV because the first stage is going to be run on the hospital level, and the second stage is on the patient level. And I'm using control function because length of stay is a highly skewed variable. It's not normally distributed. It's very skewed to the left. So I have to use control function instead of the two-stage least square. Okay, and here's the model that I was talking about, where I don't have to put more assumptions on where the heterogeneity happens. This is called the finite mixture model. So the idea is that I'm telling the model, hey, I know there must be at least two types of heterogeneity, so tell me what they are. Okay, let me show you the result real quick. I want you to focus on the second column here. So basically the second column says when the hospital adopt EMRs, they will see a drop about 10% or 11% in length of stay. When the hospital adopt both EMR and the CPOE system, drop of length of stay is about 14%. Okay, here is the interesting part. Focus on two columns of the top right-hand side here. The first column is saying these are the part of the patients that are not being affected by the EMRs. Their drop in length of stay is about 3%, not statistically significant. The second type of patients, they're experiencing about 18% drop in length of stay, statistically significant. And similar here for the hospitals adopting EMR and CPOE system. Okay, so two types of patients. The first one, not being affected. The second one, being affected a lot. Who are they? That's our next question. So this is like a posterior analysis. So I'm running the likelihood of each patient to be belonging to two different groups, and I'm running analysis just based on the patient characteristics and also on hospital's characteristics. What I'm showing up here is saying the older the patient, more likely they are in the second group, the ones that are being affected. If the patient is Black, it's more likely they're going to be affected more by the EMR system. Medicare and Medicaid patients are more likely to be the ones who are being affected. Charlson score, the higher the Charlson comorbidity, the more possible that they are the second group. Hospital characteristics, I do not find significance here except for critical access hospital. If a hospital is a critical access hospital, they are more likely to be in the first group, the ones that are not being affected more. But others, like the owner type of the hospital size, and whether the hospital belongs to any particular system, they are not showing significance here. More information about the two types of patients. The first type is the blue bar. This is their distribution of length of stay. You can tell that the first type of patients are the ones who are staying at hospitals for a shorter time period, and they consist of about 77% of the entire population. Only 23% of the inpatient population here are shown to have impacted from the EMR system, and the year length of stay is distributed longer with longer tail. Here is the Charlson graph of the two groups. If you see it clearly, there are actually two rings here in the graph. All the words out here is the different categories of the Charlsons. And the yellow or the orange line here is showing up that the second group of the patients are the ones who are having higher comorbidity. I also did a quick analysis just to stratify my sample based on different diagnosis types, and I realized I can still find similar things. So for example, here we have respiratory system or circulatory system disease. For all these different type of disease, we can still see this two type of effect, the ones who are not being affected and the ones who are being affected. And the percentage is roughly the same, from 70% to 80% of the populations are not being affected more, and the rest are the ones who are really being affected. And here are just some more information on how the effect changes. Okay, so in conclusion, the implementation of EMR system can drop the length of stay by 10 to 20%. Heterogeneous effect do exist. We can find that based on different diagnoses. And the finite mixture model shows that there are at least two type of patients, the ones who are being affected more and the one who are not being affected. And majority of the population are the one who are not being affected that much. So that's my talk. Thank you.
Hi, everybody. My name is Hilal Atasoy. I'm an assistant professor at Temple University. Thank you very much for the opportunity to discuss this paper. I really enjoyed reading it, and Ray did a great job presenting it, and I actually had a little brief chance to talk to her before the presentation, so she already answered some of my questions. But so I'll start with the strengths of the paper. There are several strengths in the paper. It has a nice, interesting research question analyzing the role of EMR on length of stay of patients and how this relationship varies by patient and hospital characteristics. She's also using a rich data source, including over 20 million patient discharge records. So this allows going beyond the hospital level averages and analyzing the outcome by different patient characteristics. And also the paper used nice empirical analysis and different methods to get at endogeneity, as well as the measurement of latent heterogeneity, such as IV and the finite mixture model. And here are some comments and suggestions that I had while I was reading the paper. So the paper starts with this motivation: the relationship between hospital efficiency and EMR adoption can be subject to IT paradox. That's been widely documented for different types of firms. And length of stay is one measure of efficiency, and the majority of the paper is about how this the relationship between length of stay and EMR varies by admission types, as well as disease types of the patients. I think the paper could really benefit from tying all these back to the original question: how do we relate this back to hospital efficiency? So one suggestion on that end could be maybe looking at the readmission rates or other outcomes that can be strictly tied to the length of stay. But if that's not possible to do additional analysis, I think there needs to be a discussion at the end to see what we learned, summarize and what we learned from these. Another question in the paper is to provide the incremental value of the CPOE over other types of EMRs. And the paper is using two separate sets of regressions. In the first one, the enterprise EMRs, the more basic EMRs, and in the second one, enterprise EMR plus the CPOE adoption. And most of the specifications, the coefficients don't look all that different. And we cannot test we cannot see the statistical significance in the difference of coefficients. So I think my suggestion here is maybe to pool all of them together and include the enterprise EMR and CPOE in the regressions to be able to test the statistical difference to establish the incremental value of CPOE over other types of EMRs. Oh, okay, sure. And the same goes for the heterogeneous effects. So the paper is looking at, this part was not in the presentation, by admission type, ER admission versus non-ER admission, as well as Ray focused a lot on different types of patients that she identified as more or less more severe and less severe patients. And all these heterogeneous effects are done by subsampling the data. So my suggestion here is maybe, again, pull the data together and use an interaction variable with those dummies or those variables to be able to see whether actually the difference is statistically significant. Because, for example, we see a coefficient negative 0.18 versus negative 0.20 from two different sets of regressions. We cannot test the statistical difference in statistical significance between those. So my suggestion is, again, to pool those and use the interaction variable to establish those heterogeneous effects that are really important for the paper. So also she presents a lot of results by different types of diseases. And that's one thing I was wondering there is what do we learn from all these types of analysis? What we see is there are differences by disease types, effects differ by disease types, but does it depend on how chronic that disease or again maybe how complex that disease is? So tying all that together to the story I think would be helpful, and it's also very challenging to look through lots of different tables and different graphs by disease type. Combining all those coefficients maybe in one plot I think would be useful. The paper uses the finite mixture model. I was not familiar with this model before. But the idea, I think my understanding is it's a model that you don't have to impose ex ante what is the heterogeneity, and the data tells you, groups the patients in this case by itself. So my question here was why we assume there are two groups of patients to begin with, if the advantage of this model is not to assume there is a certain structure. So what happens to the results, let's say if we do 3 groups or 4 groups, or is that even possible or feasible? That I don't know the answer to that. And my last comment is about the instrumental variable. So majority, almost all of the results in the paper are based on the IV. And the paper is using the lagged EMR adoption of other hospitals in the same hospital referral region as the instrument. And the assumption here is this instrument should not be correlated with the focal hospital's length of stay besides the impact via the focal hospital's EMR adoption decision. And of course, there is no perfect IV, and one can come up with many explanations where this is not true, because these hospitals are in the same healthcare market, they're facing the same pool of patients. So when one hospital invests in EMR, they might attract a different pool of patients, again changing the patient's profile for the other hospitals. So we can come up with explanations where the assumption for the IV is not valid. So that's why my suggestion here is maybe not put all the eggs in one basket and not just everything based on IV, and use some other maybe more regression-based methods such as fixed effects or matching method, and then have IV as another analysis and decrease the emphasis on the IV and not just base everything on one assumption in the paper. So those are my comments. Thank you.
Well, I can use the time. Thank you everyone for the attention at this hour. We're almost there. So, well, okay, here we go. My name is Huaxia. I'm a faculty at the University of Rochester. This is joint work with my former colleague, Susan Liu, who is a health economist. She's now at Purdue University, and with my colleague, Avi Sediment at the University of Rochester. So, without getting into any details, I would like to give you some background and a quick overview of our study before everyone gets really hungry. So this slide actually has nothing to do with health or IT. If you look at, but I think it can shed some light on how much automation can change society. If you look at the left panel, the left chart, it shows how farm productivity has increased over the last century. And if you look at the right one, focus on the green bar, you can see how the percentage of farm population has decreased dramatically over the last century. Now, if you think about how much automation how much automation the information technology has brought to us, or will bring to us, then you can sort of get the idea that you will start wonder how this information technology revolution in various industries will affect people's employment. So here I list some of the cool pictures. The one on the top left is the Google driverless car. The one on the top, on the bottom left is the actually that's a robot at a Loft Hotel in California. The one on the top right is a restaurant in China where the robot basically serves as a waiter. And the one on the bottom right is teddy bear-like robot that can lift patient in a hospital or nursing home setup. So if you think about this, then, and now as healthcare researchers, we will naturally think about, okay, with so much new technology, so much advancement in IT that are employed or will be employed in the healthcare industry, then what is the implication? And it turns out that we're not alone in this concern. This is a quote. The rollout of electronic health record systems is identified as one of the dangerous trends that nurses must know about. So this is actually from a leading article in a well-known magazine last year. So here's our research question. How will IT-enabled automation affect healthcare employment? Now, as I said, this is going to be an overview. I'll use 2 slides to give you a quick overview of what data, what methodology we use, and what we find. So our context is nursing home. I'll explain more why we focus on this particular sector of the healthcare industry. And our methodology-wise, we actually developed a theoretical model, an analytical model to get some testable hypotheses. Then we use data to empirically support the predictions by the model. And here's a quick overview of what we find. So we find that IT-enabled automation will actually reduce staffing by about 5.8% in high-end nursing homes. By high-end, I mean nursing homes that enjoy relatively premium brand name or that are higher up in the vertical, with higher vertical position in the whole industry. But it will increase the staffing by almost 8% in low-end nursing homes. So the message from the first finding is that the implication of automation enabled by IT is complicated. It's not necessarily a substitution theory. We also find that IT-enabled automation improved patient satisfaction by almost 37%. Finally, we find that there's about 15% significant decrease in admission of the Medicaid patients. I'll explain more about this part later. So that's the brief overview of our finding. Now we'll get more into the details. First, let me give some background about nursing homes. So why do we study nursing homes? Well, first, it's big. It has about, here I have one statistic. In 2011, about $111 billion spent on nursing home care. But the main reason for us to focus on this particular sector of the healthcare industry is because of simplicity, both in terms of the labor's provision structure and also in terms of type of service they provide. So if you compare nursing home with hospitals, you will see nursing home has a much simpler structure. Most of the labor provision is by nurses. Now, I will use 2 slides to explain more details about this particular healthcare sector. From the demand side, there's industry jargon called quality mix. The reason why this becomes important is that patients at nursing homes, they use different methods to pay. For example, Medicaid, Medicare, and private insurance. Now, for Medicaid patients, the daily rate is about $194 from this year's data. But for Medicare, the rate is about $500. So you can see there's a drastic difference. And for private pay insurance, it's also pretty high. So naturally, you would think, okay, everyone should try to grab as many patients not from Medicaid as possible so that you can have a better profit margin. Well, they can't discriminate based on the type. So there's a regulation on that. So the term quality, this term quality mix is used in the industry to refer to the percentage of non-Medicaid revenue. So the higher the quality mix, the higher the profit margin. Now, from the supply side, nursing homes, the entire nursing home industry is highly competitive. And naturally, from the economic theory, you reach the conclusion that there will be vertical differentiation. And this is indeed true. And if you use the nursing home compare star rating system, you can see there's a lot of difference among different nursing homes. This is one measure of the vertical position. Another measure which we will use in the study is the staffing level. So the higher the staffing to resident ratio, the higher the service quality and higher the star rating. So this is established in the literature. So we'll actually use the initial distance between the staffing level and the state mandated minimum staffing standard as a measure of the vertical position of nursing home. So now let me just spend a few minutes talking about our theoretic model, which leads to the three hypotheses that we're going to test. So our model starts with one basic idea. For a nursing home, the decision variable is how many staff should I hire, or put it in our context, how should I optimally decide my staff to resident ratio? And we model this as a decision, and this R is defined as the staff to patient ratio, which will then affect the quality of care provided by nursing home. We also include a parameter K, which indicates the level of automation. Later on, we will use a simple dummy variable, which basically the adoption of CPOE to indicate level of Ka that they will use. So this is the quality, how the quality is determined by the staff to resident ratio and by the technology, the automation level. Now, a unique feature about nursing home is that quality affects profitability mainly through patient composition rather than the patient volume. If you think about a lot of economic models, then mostly when you improve your quality, you attract more demand. So you get a higher volume and your profit will be better. You get more revenue, more customers. But something is unique here about the nursing home industry. For example, if you look at the occupancy rate over the years, it's pretty much flat. Also, at the very end of my talk, I'll show you some more empirical evidence of why the total demand is sort of fixed. It also has a root in the regulation about how many more beds can you build. So the message, and also here you can see, if you have higher staff to patient ratio, your quality mix will be higher. So this is something very unique about this industry. That's why we model this in a very novel way. We assume the demand is one. The demand does not change as you improve your quality. Rather, as you improve your quality, your average revenue per patient will increase because more non-Medicaid patients will be attracted to your facility. So that's our basic assumptions. And then we basically solve the optimization problem for a nursing home. And another thing that's very important is we introduce the parameter theta into the model, which is basically determined by nature. Now, theta later on we will interpret as a vertical position. So right now, just think of theta as something that's drawn by the nature, assigned to each nursing home. And our first finding is that, okay, the optimal staffing level, the optimal quality level, and the average revenue per patient, they're increasing in theta. So this result basically allows us to interpret this theta as the vertical position. So we didn't define vertical position in the model. Rather, we introduced exogenous parameter here, and then let the nursing homes solve the optimization problem, and they figure out, and it turns out that the higher theta you are endowed with, the higher the higher quality you will provide. So we naturally interpret this theta as the vertical position. Now our second result shows that if you increase your automation level through health IT, then your optimal quality level will also increase. So this is like saying, okay, well, basically like a testimony of why you should adopt health IT, because it can improve your quality. Now, this part is what we are most interested about. So what this is saying is that if your vertical position is smaller than a certain threshold, then an increase in automation level will actually increase your staffing level. So if you are at the lower end, then an increase in your automation level means because of your optimization problem, you will increase your staffing level. On the other hand, if your vertical position is above that threshold level, meaning you are basically at the high end, then you will optimally choose to decrease your staffing level after you adopt some new automation technology in your nursing home. So that's the prediction from the model. And we basically translate into English to get the 3 hypotheses. And now we want to find empirical evidence to these 3 hypotheses. So our data mainly comes from 2 sources. One, the OSCA data, which gives us information about nursing homes. And my co-author actually, she hand collected a lot of the data from there, so a lot of work. And we also get the health IT adoption data from HIMSS. Some of the key variables, we use process quality instead of outcome quality to measure the quality level. Later on in our robustness check, we also use some clinical outcome. The staff-to-patient ratio, we use the staff hours per resident day, which is very standard in nursing home literature for licensed nurse. And we also extend to different, like registered nurse, only registered nurse, for example. The vertical position, as I said, we use initial distance between the staff-to-patient ratio and the state mandate minimum staff-to-patient ratio. So our econometric model is very just a common model where we have this IT adoption effect here. So we want to test this alpha 1, and this could be process quality or could be staffing ratio. So econometrically, it's nothing fancy here, but of course the challenge here is the endogeneity with adoption. And our solution to this is to construct a instrument variable which describes the yearly hospital CPOE adoption rate in the local market. Here, a local market is defined at the county level. So the idea is that the upstream, because a lot of patients from nursing home, they are sent through the hospitals. So the idea is that hospital adoption level will affect your adoption level, your adoption decision at your local, in your, so hospital is like upstream and nursing home is like downstream. So your upstream decision will affect the downstream decision because of network effect or any other kind of communication. It makes this easier. On the other hand, the upstream hospital adoption decision will not change or affect your decision about your staffing. So that's the basic assumption in our of the validity of our IV choice. And we also use an alternative IV where we basically saying, okay, let's forget about those hospitals that are affiliated, well, those hospitals that has affiliation with the nursing home to tease out some of those tricky things. So these are IV we tried, and here are our finding in terms of number. So this one shows the effect of CPOE adoption on the patient complaints. So we didn't find anything using OS. In the 2-stage least square, we find that it can significantly decrease the patient complaint. So that's basically an evidence for the second hypothesis we have. Now this finding is about the staffing. So if you look at the, let's look at this one. With high end, it's basically a dummy variable indicating whether a nursing home is at high end or not. So now, if you adopt CPOE, you will increase, because it's significant positive, you increase your licensed nurse staffing level. But if you're at high end, then there's significant negative effect. And the overall effect on high end nursing home is negative after we do the F test here. Now, after we did this, now we start thinking, okay, so is it really caused by the change of the customer composition? So we did this part of the test. So basically now we're replacing the dependent variable by the patient types. The total admission, there's not much difference. So basically, if you adopt CPOE, your total admission will not change much. But your Medicaid admission decreases. As I said earlier, the Medicaid admission actually hurts your profitability because they pay at a much lower rate. So what are the takeaways from our study? First, for the individual nurses, this is like sending a message to that magazine, National Nurse. There's no need to panic. IT-enabled automation does not necessarily mean there's a substitution. In fact, there are two competing factors playing here, both the substitution and also the competition. So for managers, basically the messages from our model. High-end nursing home managers, they should pursue a cost-saving strategy here, while for the low end, they should pursue the revenue expanding strategy. And these are the insights.
Sorry, could you wrap up, please?
Yes, sure. 10 seconds. And for the policymaker, I think it's a clear message is you should encourage technology adoption because it improves quality. Thank you very much.
Oh, there we go. Very brief on the summary, since we're very short on time. Basically, it's the effect of CPO adoption on staffing decision in nursing homes and quality. Motivating model of supplier's quality choice. You instrument CPOE adoption with county-level hospital CPOE adoption rates. I should have bolded hospital here because that's a different provider that's important. You have a fixed effects methodology, so basically everything is happening across time. Your findings are CPO adoption increases measured quality, increases staffing in initially low staffing homes, decreases staffing in initially high quality, high staffing ones. Overall, you raise revenue by improving the payer mix. Go away from the lowest paying kind of payer Medicaid. Like I said, interesting results. Especially interesting the heterogeneous effects by initial vertical market position. So there's some really interesting economics going on here. It speaks to highly relevant questions. What's the impact of health IT on quality? Isn't this what we all want to really learn about? Also, how does it interact with the other factors of production? And just in general, any analysis that that acknowledges that these entities are optimizing agents and not automatons is bound to give more meaningful results. I also think it dovetails nicely with recent work on endogenous quality choice. Martin Hackman at Penn State actually has a very nice and elaborate structural model on the nursing home industry that has some results on the interactions of payer mix and quality choice. So I think your contribution and his kind of work can really cross-pollinate each other quite well. I like the alternative instrument as a robustness check. I was reading and thinking, oh, but isn't that just mechanical? Couldn't it just be co-ownership? And right in the next section we saw it, so that was great. What are comments that I think could help the reader be guided along in this paper? Your effect of CPOE on measured quality, as it is now, doesn't control for any staffing changes and therefore should be interpreted as the overall compound effect of both CPOE adoption and any resulting staffing changes. Since in the other specifications you actually find some effect, it's heterogeneous, but you find some effect on staffing. So the staffing must play a role, and it would be good to either put it into the equation directly or at least report the straight staffing level effect without interactions to let the reader kind of figure out a average effect themselves, even though the linearity you rely on there is not necessarily always warranted. Overall, another remark on the interpretation of the results. Both in your model, as you say, in your model you hold the initial quality levels, vertical levels, exogenous. I think that's an absolutely reasonable choice. As an IO economist, of course, I see this and say like, wow, what's going on there? I want to learn more. But for the scope of your project, it's an absolutely reasonable choice. Similarly, you take it as given in your empirical analysis, but I think that in this turn now affects how we should interpret these results. So I think these results can be read as kind of something like an average treatment effect of CPOE adoption at the time of the sample in a world where 70 to 80% haven't adopted yet. Since quality plays such an important role in this market and profitability, what we really, as adoption becomes more widespread, we really do expect the market to equilibrate differently and then lead to overall different outcomes in the end. So that's about the interpretation of the results as they are. Now on to the IV assumptions. You instrument CPOE adoption with the local of nursing homes with the local share of adopters in the hospital market of CPOE. I think it's you didn't have much time in there. Let me just give you a little explanation of what the indigeneity they're worried about is. They're worried that as CPOE adoption happens, for example, after a year where you have really bad quality. So managers together say, what can we do about this bad quality? Well, we can install a CPOE system, sounds good. They do it. You improve, you might improve based to that, compared to that bad year you had, but the if you just took this as face value, it might not necessarily improve it compared to the overall sample average of that nursing home. So that's basically the heterogeneity they're worried about. What do? They instrument with hospital CPOE. So there are always two assumptions, informally speaking, have to be true about instruments. Does the instrument affect the endogenous variable? Here, I'm absolutely 100% on board. Actually, this afternoon I'll be standing here and trying to show you evidence, trying to convince you and show you evidence of the importance of cross spillovers and EMR adoption across different kind of providers. What about though the exogeneity assumption that that instrument doesn't otherwise affect the outcome? Here, I'm not all that sure. And the thing here is, would it be in a hypothetical model without fixed effects? Would you believe the assumption? Probably not. The Boston area probably has higher CPOE hospital levels, probably has higher nursing quality levels on average. Now, of course, that's not what you do. You have a fixed effect model, and therefore all this variation is across time. You have state fixed effect, you also have year fixed effects on a national level, and you have linear state time trends. So lots of controls here, and what that's, on one hand, this is good, because it takes a lot of these heterogeneity of the instrument stories off the table. On the other hand, though, it leaves you with an object of, with the residual variation after parceling out all of these controls that is hard to wrap your head around as a reader and makes it difficult to assess the validity of the instrument. And all the other things are smaller details that I think we can talk about offline. Okay, thank you.
My background is in nursing home quality of care, so I have two questions for you. One is, how did you measure the patient satisfaction? Because these are elderly, demented nursing home residents, and in large part, so just curious how you measured patient satisfaction and what your theory is about why it improved so much. Do you think it was because the patients really realized, the residents really realized that the nurses have more time now to talk to them? Do you think that's true? Did you do any correlations to quality? There's a ton of quality measures for nursing home patients. So did it actually increase quality of care, quality outcomes? So those are my questions.
Thank you for the question. So the first point, the quality measure we use is process quality, basic customer complaints. So that data is from OSCA. The OSCA data, they provide that complaint along different dimension. I think the origin of the data is that as a patient, you can complain to the CMS by calling them or using any other communication method to telling them some kind of incident or something you're unhappy about, and they will start investigating that. And once they get confirmed, there will be a record there, and that data somehow becomes available to us. So that's how the data comes from. So and then, do I truly believe that adoption of CPOE or any other information technology can improve quality? Yes, I do. The reason is because, for example, if you think about nursing homes or even hospitals, nurses, they spend a lot of their time actually not spending time, not with the patient. I read one study that indicates almost half of their time are spent hunting down supplies, walking along the halls, and or even looking for a battery. You know, that's like 50 or 60% of time they're actually wasted. So there are a lot of inefficiency there. Now with the CPOE, for example, a lot of their work can be streamlined. For example, let's say they want to check some of the medication, they just have their tablet, they bring it out, then they don't have to go back to the documentation room to find out that paperwork. Instead, they can just bring it out immediately, and then they can use the same device to communicate with the doctor's office, or connecting with the pharmacies. So a lot of work can be done while they are at the bedtime. So they just can at the bedside of the patient. So they can definitely spend a lot of time communicating with the patient, understand their needs. So I think that could drive down a lot of the complaints they can potentially have.
So the underlying assumptions in both of your presentations, to my understanding, is there are three implicit assumptions that maybe you tackled, maybe I missed, maybe it's in the paper. One is the adoption of IT or AMR is exogenous to the market forces. The choice is not a function of those market forces. I think you may want to tackle that one. The second one is once these institutions adopt the IT or AMR, the way the presentation sounds like you are assuming that it has been effectively and efficiently used by those institutions, which is another issue. And the final one is, in both of your models, your exogenous or right-hand side variables, the assumption is there is no differential impacts of those variables on the adoption of IT or AMR. I think both of these studies will benefit if you tackle those three dimensions. And one of the discussants was talking about the problems in the IV selection, which I agree with that. One thing that as an HCAP team we do is we do the dirty work to make sure that the researchers use our data in the best possible way. And one thing you may want to do is we have developed the competition, the Herfindahl index for all those, for different types of market segments. One can assume that if the adoption of AMR has no financial incentives, then it could be possible that that has nothing to do with the hospital competition. Like, we can use that as a case test possibly. The reason I'm sharing this with you is, like, I think both of these papers, either as a discussion or as a limitation or maybe the sensitivity analysis, will benefit further from these additional steps. Thank you.
Thank you very much.
I just want to add a little bit thing. I think that's indeed one of the limitations that when I'm using the information on the health IT system adoption is combined with earlier years of HIMSS data sets, so there is not too much more information on the exact what they're doing with their system. I can only see that whether the system is running, and I think they do ask for like employment, how much full-time employment is related to the systems, but the response rate was really low. And also to tackle like how much well or how much badly that the hospitals are utilizing the system, I allowed for 1 year